Great, thanks, John. So welcome everyone, and thank you for joining us today on a topic very important to our communities, Indigenous wellness, a conversation on long COVID. It's been over 3 years since COVID-19 began its spread across the globe. And as the world and our Native communities continue return to a new normal, there is still much to learn and share about the long-term effects of a SARS-CoV-2 infection. The COVID pandemic has hit American Indian and Alaska Native communities particularly hard. CDC data shows that compared to white non-Hispanic Americans, Indigenous people have been 2.5 times more likely to be hospitalized and 2 times more likely to die. Over the first 2 pandemic years, Native life expectancy plummeted by 6.5 years. The impact of the pandemic will be felt for years and generations to come. This webinar, with information targeted to UIO healthcare workers, will explore clinical presentations of long COVID and risk factors for developing long COVID. Our lecture today will be followed by a discussion, and we want to hear and learn what you see in your communities and understand about what the support and resources that you as frontline workers or working with COVID patients might need. Please note that this webinar event participants can earn continuing medical education credits or continuing nursing education credits by attending this event. My name is Liz Best, and I'm a manager of technical assistance with the Technical Assistance Research Center, otherwise known as TARC here at NCUE. And joining me from the NCUE team are Molly Siegel, Public Health Associate. She'll be helping out in the chat room, and also Sean Bitsui, who will be helping out with the production today. We're honored to have you all here, and we kindly ask that you place your name, your organization, your tribal affiliation, and title into the chat box. In addition, we welcome any feedback you would like to provide about your webinar experience in our survey, which Molly will also share in our chat box. Next slide, please. For those of you that are new to the work of NCUE, here's a little background. The National Council of Urban Indian Health is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indian and Alaska Natives living in urban areas. Next slide, please. Please note that this session is being recorded for educational and quality control purposes. Next slide. As shared today, we're able to offer this webinar for CEU credits. This activity is jointly provided by NCUE and Cardia Services. Cardia Services is approved as a provider of nursing continuing professional development by the Montana Nurses Association, and accredited approver with distinction by the American Nurses Credentialing Center's Commission on Accreditation. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the California Medical Association through the joint providership of Cardia and NCUE. Cardia is accredited by the CMA to provide continuing medical education for physicians. Cardia designates this live web-based training for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim credit to measure it with the extent of their participation in this activity. Next slide, please. Please note that there are no relevant financial relationships with ineligible companies for those involved with the ability to control the content of this activity. Next slide, please. So upon successful completion of this activity, 1 contact hour will be awarded. Successful completion of this continuing education activity includes attending the entire webinar, completing the online evaluation, and then submitting an online CEU request. Your certificate will be sent to you via email. If you have any questions about this CE activity, please contact Fiona Morrison-Fleming at Cardia. Next slide, please. A few quick housekeeping items. If you care to, please turn on your video. Please mute your microphone when not speaking, and we will have a time at the end for questions and discussion. And as stated earlier, please enter your name and organization in the chat box so we can see who's attending today. Next slide, please. And then quickly, for those of you who are new to a Zoom platform, you'll find the chat box at the bottom of the screen. If you do have a question or a comment throughout, please feel free to click on the chat box and we'll take you to an area where you can enter your question or comment on the right. Next slide, please. But before we get started, just a little overview of the agenda for the day. We're going to start off in a few minutes with an online poll, and then I'm pleased to introduce our lecturer, Dr. John Baratta, who will be discussing the clinical aspects of long COVID. And then we'll have a discussion on long COVID followed by Q&A. Next slide, please. So to get started, I'd love to start off with a little poll just to check our knowledge on long COVID and how it may be impacting our communities. Sean, you can bring up the poll. And if you haven't done an online poll, it's pretty easy. You can just toggle your mouse over to little circles and click the answers that you think are correct. It's only 5 questions. And when you're done, feel free to drop an emoji into the chat box so we know that everybody's finished. Great, I see some happy and lunch emojis dropping in. All right, so let's see if you got your answers correct. Great, so the first question, nearly 1 in 5 American adults who have had COVID still have long COVID. 100% true. What is the most common long COVID symptom? And that would be fatigue. 88% of you got that question right. Who is at risk for developing long COVID? Children, adults, those with, that should be mild symptoms, those with severe symptoms, all of the above. Yep, everybody's at risk of getting long COVID. Women are more likely than men to currently have long COVID. The answer to that is true. Current research is pointing to that area. And then lastly, there are more than 200 symptoms that can be linked to long COVID, and that is true. So it seems like you guys have a lot of basic knowledge on long COVID. To expand on that, we're very pleased to have our guest speaker today. Next slide. So without further ado, I'd like to give a warm welcome to Dr. John Baratta. Dr. Baratta is a board-certified physician practicing physical medicine and rehabilitation. He attended medical school at Wake Forest University and completed his residency training at the University of North Carolina, Chapel Hill. He is currently an assistant professor at the UNC School of Medicine, where he serves as co-director of the COVID Recovery Clinic and director of stroke rehabilitation. Dr. Baratta, please take it away.
Thank you, Liz. Hi, everyone. It's great to have you all here today. I am impressed with your initial knowledge on the quiz, and hopefully we can build on that somewhat and discuss other and some more recent other aspects of long COVID and more recent developments. Next slide, please. So we'll be talking about long COVID during my presentation today, also known as post-COVID conditions. When we first started the UNC COVID Recovery Clinic, I was expecting it to be primarily a clinic that catered to people who had been critically ill with COVID. This was back in 2020 when we first started planning for it, and we began seeing patients in the post-COVID clinic in early 2021. And while we certainly do see those patients who have been critically ill and who were on the ventilator, by and large, the majority of our patients who are seen in the long COVID clinic had a mild or moderate initial illness to where they didn't need to be hospitalized. So over 80% of our patients seen in the long COVID clinic actually were not hospitalized. And I think that is that's been a surprise to me as far as post-COVID care, and we certainly see that, that trend continuing as time goes on. Next slide. So our agenda for the time together today during this presentation will be firstly to review fundamentals of post-COVID conditions, long COVID, and also to briefly discuss the evaluation and management of common symptoms. As we had touched on in that in the poll, there are hundreds of symptoms attributed to long COVID, and so it can't touch on all of that within 30 minutes, but we will hit the highlights and hopefully give some good take-home points for you all. I'm glad to see the groups represented here today, including nursing personnel and social work. Long COVID care will be required in some capacity by all throughout the healthcare, by all throughout healthcare delivery, physicians, nurses, therapists, social workers, and others. So I'm glad to have you all here. Next slide, please. So this slide represents a conceptualization of post-COVID conditions as a term. Post-COVID conditions I consider to be an umbrella term. And in that umbrella, there are a number of other terms that you may use or have heard of, obviously including long COVID, which is a colloquial and frequently used term, PASC or post-acute sequelae of COVID, long haul, long-term effects, late sequelae of COVID, and others. But really, these are all interrelated terms. They're synonymous, and post-COVID conditions can be a larger term that encompasses all of them. Next slide. So what is a post-COVID condition? It can be hard to define, and you all may have seen this already in some of the patients that you are caring for, because for different people, long COVID or post-COVID condition means a very different thing. But most broadly, a post-COVID condition could be considered a medical syndrome in which there is a lack of return to a usual state of health following the acute COVID-19 illness. And that phrasing comes from the CDC. And I like that because it encompasses not only new conditions, new medical conditions that were not present in any capacity before COVID, but also a worsening of pre-existing medical conditions, such as diabetes, for example, where we see many patients with more challenging blood sugar control after COVID-19. A post-COVID condition or long COVID diagnosis requires two criteria. First of all, there needs to have been a prior COVID-19 illness. And this could be a confirmed illness by testing, or alternately, it could be a presumed illness in the event that testing was not available, or the possibility of a falsely negative test. But conceptually, a prior COVID-19 illness has to have occurred. And then there also have to be lingering symptoms or health effects. And usually the time cutoffs for these health effects are 1 to 3 months or more than that. And we'll touch more on the duration and the time course in a few minutes on a subsequent slide. The figure on the right side of the screen shows some organ systems that are commonly affected and associated symptoms. So including the cardiovascular system, where patients might complain of chest pain or palpitations. And there are reported diagnoses including myocarditis or POTS, which is a type of dysautonomia. Obviously, COVID is a primarily pulmonary condition, especially the earlier variants of it. So cough and shortness of breath with reduced gas exchange are key factors for people who are experiencing persisting effects. And the list goes on across a variety of organ systems. Similar to acute COVID, which can seemingly cause many types of symptoms throughout the body and mind, long COVID can likewise affect people in quite dramatic ways. Next slide. So for those who deliver medical care and who might be responsible for assigning or recommending codes for patients, I would encourage you to, instead of using the broad and vague term long COVID, I'd encourage you to use a more specific one, such as post-COVID fatigue, post-COVID memory impairment, dyspnea, headache disorder, etc. As of October 2021, we now have ICD-10 codes, which are specific to post-COVID conditions. The broadest code is U09.9, which is post-COVID condition unspecified. But the ones that I list above are included under that code umbrella and can be utilized for patient care. And there are many other post-COVID symptom codes that could be utilized. Long COVID is what people will still use when they come into clinic or discuss their condition. But for the purposes of documentation and communicating with the patient and other medical providers or healthcare workers, using that more specific terminology can be beneficial. Next, please. And so long COVID generally is associated with a ongoing symptom or set of symptoms. And depending on the organ systems that are affected, this may, in certain cases, lead to an increased risk of death. So for example, someone with pulmonary fibrosis, a scarring of the lung tissue related to their prior COVID illness, would have a higher risk of mortality related to this post-COVID condition. And as such, there is a known increase in mortality for those who are struggling with long COVID symptoms. Unfortunately, health inequities may put certain population groups at greater risk for long COVID. And as seen in this graph here with data supplied by the National Center for Health Statistics, the risk of death related to a post-COVID condition is considerably greater for American Indians or Alaska Natives. Likewise, for acute COVID, which is the blue line in this graph, American Indians and Alaska Natives are also at higher risk than other population groups for an adverse outcome. Next slide. So let's dig into the timing criterion of post-COVID conditions a little bit more. There is some debate. There's not full alignment on the timing of what would be a post-COVID condition. The CDC here in the US suggests that 4 weeks is a cutoff that can be utilized for calling a persisting health effect or symptom a post-COVID condition. Outside of our country, in the UK, for example, at the National Institute for Health and Care Excellence, and also at the World Health Organization, 12 weeks or more is utilized as a cutoff. Now, when speaking with people who have a post-COVID condition, it's important to emphasize to them that they are not contagious related to the post-COVID condition, unless they have a reinfection with acute COVID illness. But that has been a point of confusion for some of our patients who are not sure if they can still transmit the virus. And really what they're dealing with are the health effects of the virus and not the ongoing acute illness. Next slide. Post-COVID conditions are a major issue in our country and globally. Beginning in June 2022, the National Center for Health Statistics, which is associated with the CDC, added long COVID questions to a monthly national household survey. And this shows that on surveyed adults in the US, 14% or so report having experienced long COVID. And this translates to tens of millions of adults in our country currently experiencing long COVID. As a percentage of US adults is also close to 20 million. Any activity limitations related to long COVID and also significant activity limitations are also included in this survey and show that many people in our country are impacted and reduced in their ability to do a variety of activities, and that may include duties at home, with work or with school as well. Next slide. So to help conceptualize post-COVID conditions, we can consider this figure, and you can share the rest of it, please. Thanks. You can just advance through. So the people who were hospitalized for acute COVID are at higher risk than those who were not hospitalized for developing a post-COVID condition. Probably on the order of 20 to 30% of those who were not hospitalized will have persisting symptoms at 30 or 60 days. And there's a higher percentage for those who are hospitalized. As time goes on, as we get farther out from the onset, those two patient groups or cohorts probably blend together to some degree, although the hospitalized group likely remains at a higher risk for long-term or lingering symptoms than the non-hospitalized group. And at 1 year out, probably it's under 20% or 10% for people to have continued symptoms related to their prior COVID illness. Things that put people at higher risk for developing post-COVID conditions include presence of pre-existing conditions, female sex, and also infection with the Delta variant. Fortunately, the more recent variants, the currently circulating Omicron, has a lower association with long COVID symptoms, although they are still a substantial concern, particularly with how contagious Omicron is. Also, for those who were previously healthy and also more vaccinated, there is a lower risk of developing a post-COVID condition. Next slide. Post-COVID recovery is quite variable, and depending on the type of symptoms and health effects that a person has, the recovery trajectory can vary. So for a more straightforward symptoms such as post-COVID headaches, in the absence of a neurological deficit, such as stroke-like symptoms, we should expect that for most people, post-COVID headaches would gradually resolve with time and likely be associated with a more complete recovery. For someone who has pulmonary fibrosis or scarring of the lung tissue, that's a more static injury to the ability to transmit oxygen across the lung membrane. Scar tissue doesn't heal well, and this is something that should be expected to remain about the same with time. Others experience a chronic fatigue syndrome, CFS type picture, also known as myalgic encephalomyelitis. And this is associated with a waxing and waning type presentation, and also frequently seen with a lower rate of recovery. So when we are asked about what the prognosis would be for a particular patient, we really need to reflect on what types of symptoms does the person have, and that guides us on the discussion. Next slide. So let's move into the second half of my presentation, which will involve a discussion of evaluation and management of common symptoms. Next. As I was mentioning just a moment ago, there are different types of patient symptoms, and this could be called different phenotypes or patient clusters. And 5 of the most prominent patient clusters that we see are listed here. These include patients with fatigue, dysautonomia or POTS, those with respiratory symptoms, pain syndromes, and also neurologic and cognitive symptoms. So in the coming slides, we'll touch on each of these primary patient symptom clusters and discuss the best approach for evaluating and managing those conditions. Next. We'll start with fatigue, which is the most common post-COVID symptom. And so when we evaluate people for fatigue, we want to make sure that a standard and appropriate medical assessment has been done to look for mimicking conditions and treatable fatigue causes. And these things could include anemia, B12 or iron deficiency, vitamin D deficiency, thyroid problems, muscle inflammation called myositis, and also adrenal insufficiency, which could contribute to low energy. The lab panel that we commonly use is listed on the right, and this includes checks of blood counts, glucose, thyroid profile, vitamins B12 and D, a ferritin check, ANA, creatinine kinase, inflammatory markers with CRP and ESR, and also a morning cortisol level. Please note that there are labs that are accessible to patients who suggest that they can check for biomarkers and other more advanced aspects of long COVID testing, such as interleukins or cytokines. We find that tests like these are limited in their utility. They're also expensive for patients, and a lot of times it's an out-of-pocket expense that really doesn't point in a clear direction to how a person could be treated. So we don't recommend labs that are out of the ordinary, not at this time. Next slide. For treating fatigue, we encourage, first of all, a discussion about the role of energy conservation. And the reason for this is because many people with post-COVID fatigue have a limited or lower reserve of energy. So this means that they don't have as much ability as they previously did to do a variety of activities. And accordingly, people need to, unfortunately, scale down their degree of activities for a period of time. This includes not only physical activities, but cognitive ones, because they can both be fatiguing. So by educating our patients about energy conservation techniques, including a concept of pacing, which is staggering the days or weeks activities so they're not too grouped together. This is a really important concept and serves as a foundation approach for managing post-COVID fatigue. The goal and the hope is that with time, the body can increase or improve its energy reserve, and the person can accordingly increase the activities that they're doing. But we do find that patients who overexert themselves and put themselves into a symptom exacerbation, like a crash or increased fatigue, these people tend to have a slower recovery trajectory. We also want to make sure that patients are being treated by a therapist, if appropriate, like a physical and or occupational therapist, to help gradually build their endurance again. We don't want therapists pushing patients too hard to the point of exhaustion, but some slight continued movement and activity is useful. Having accommodations at school or work is also useful to reduce the overexertion. Additionally, it would be important to treat comorbid conditions, including depression and sleep disorders, which can contribute to fatigue. We sometimes also use medicines to help patients with fatigue. Frequently, this includes activating antidepressants and stimulant medications to help boost energy. Next slide. Pulmonary symptoms are common after COVID, and dyspnea and cough are two of the most common pulmonary symptoms. So it is reasonable to proceed with a standard medical evaluation for these types of concerns. And this would include pulmonary function testing with and without bronchodilation, and also with DLCO, which is the diffusion coefficient of carbon dioxide. And this is important because the DLCO is the most common abnormality for people with long COVID. When there is a reduced DLCO, this is evidence that the lung membrane is not transmitting oxygen efficiently, and this can contribute to lower oxygen levels in the blood and accordingly shortness of breath. Imaging such as a chest CT could be considered, and also a sleep study is a consideration for people particularly with persisting dyspnea. Consider also the possibility of a pulmonary embolism. We have seen that in a few of our patients, even in the more subacute or chronic phase after outside of the acute COVID illness. Next slide. So for management of cough, we usually recommend typical treatments for post-viral cough, including cough suppressants. And oftentimes we recommend breathing exercises for dyspnea or shortness of breath. Across both of these symptoms, inhaled medicines such as albuterol and or a steroid inhaler could be considered. Cough usually improves. This is not typically a symptom that we see patients have a major issue with several months down the road. But dyspnea is more persistent. And in those cases, we recommend pulmonary rehabilitation, which is a special type of physical therapy to help recondition the lung musculature. There are also some breathing exercises that are available online and on our patient handouts, which I'll share with you towards the end of the lecture. These seem to be useful because some patients have an altered breathing mechanism after COVID, where they tend to take more shallow and shorter or more frequent breaths. So by retraining the respiratory system to take fuller, slower breaths, this can be helpful. A pulmonology consultation can also be considered for patients with persisting symptoms. Next slide. Dysautonomia is also a common issue that we see. The autonomic nervous system is part of our nervous system that helps to control involuntary involuntary body activities, including breathing, the beating of the heart, and peristalsis in the GI tract. So when there is dysfunction of the autonomic nervous system, termed dysautonomia, there can be a wide variety of effects. The most common one that we see in people after COVID is called POTS, which is postural orthostasis tachycardia syndrome. This is a medical term which essentially means that there is an excessive heart rate rise when people change their position, going from lying to standing, for example. This is different than orthostatic hypotension because the heart rate, while it increases, it's not associated with a blood pressure drop. So that's a little nuanced. But we have gotten used to seeing a lot of people with dysautonomia. And tilt table testing could be useful to diagnose, although in our clinic, just practically speaking, we do a just an orthostatic test where we have patients start by lying, we check their heart rate and blood pressure, and then we stand them up and check it several times over about 5 to 10 minutes to observe how their vital signs change. Next slide. The approach for managing dysautonomia is both non-pharmacologic and pharmacologic. First of all, we want to encourage people to stay very well hydrated because that can reduce the heart rate exacerbations. And also salt loading with a large amount of salt or sodium is important to boost blood volume and reduce the dysautonomia. Compression stockings, at least medium compression and thigh high if possible, are good to help reduce symptoms. And we counsel people to avoid exacerbating factors such as dehydration, alcohol, and medicines like diuretics. Recumbent exercise, where a person can condition their body in a seated or lying position, is also useful. Next slide. There are drug treatments as well, including beta blockers, fludrocortisone, which is a steroid to help boost blood volume, and some other medicines listed here that could be considered by the medical provider. Next slide. Neuropathic pain is a concern as well, and people with this type of symptom can benefit from having a standard neuropathy workup, including some blood values such as B12 and TSH, and an EMG, electromyography, to test the functioning of the nerves and muscles. Small fiber neuropathy is an etiology for symptoms that we see more commonly now that we know to look for it. There have been some recent case reports and series that show that small fiber neuropathy is common. This seems to have overlap with autonomic dysfunction. And so when someone has dysautonomia, looking for small fiber neuropathy is a reasonable thing to do. They could be related. People with small fiber neuropathy, in addition to having orthostatic intolerance or inability to stay upright, can tend to have pain or paresthesias, and medications such as listed here could be considered for treatment. Next slide. Myalgias and arthralgias are also frequently seen, and for these types of symptoms, we would consider blood work as listed here. It's like a rheumatologic panel, and in addition to what's listed here, other labs could be added depending on the patient's presentation. It's important to note that most markers, are negative. Most labs return as normal, but sometimes we do catch abnormalities, and it would be important to treat those if so. Rheumatologic evaluation could be reasonable for some of these patients, and providing symptomatic treatment such as with turmeric or other anti-inflammatory supplements could be useful. We also do use NSAIDs and steroid bursts, as well as diclofenac gel to manage these symptoms. Next slide. Neurologic symptoms can be very common and wide-ranging. Cognitive dysfunction is the most bothersome and most commonly seen. This typically results in impaired attention and executive dysfunction. Patients will frequently say that their memory is shot, or they just don't remember like they used to. And in reality, what we're finding and what others have seen is that it's not as much a memory problem as it is an attention problem. And so the impaired attention leads to the memory challenges. Headaches, dizziness, and tremors are also frequently seen as well. Next slide. So the management for cognitive dysfunction is in part similar to the approach for fatigue, and that is minimizing triggers and allowing for rest breaks. reducing the intensity of work and other activities. But for cognitive dysfunction specifically, we rely a lot on the consultation and treatment by speech therapists who can offer a service called cognitive rehabilitation, which are basically brain exercises that can be done in the office and also at home to help improve attention, focus, and also provide compensatory techniques to minimize the impact of these symptoms on someone's life. Neuropsychology testing, which is formal evaluation of the symptoms, could be helpful, particularly for those who have work-related issues or school challenges, because having that objective testing can provide some support to the person. And stimulants, such as listed here, are also helpful. And guanfacine has shown some early promising results as well. Next slide. So as a little take home, here's kind of a below sheet for things that a medical provider or a health worker might look for, and ways to manage as well as evaluate symptoms in people with post-COVID conditions. Please feel free to refer to this in the future. Next slide. There are some established post-COVID condition guidelines now, such as through the CDC, also through the American Association of Physical Medicine and Rehabilitation, which has now published 7 guidance statements on the most common symptoms, including fatigue, cognitive dysfunction, dyspnea or breathing issues, cardiac symptoms, and others. And up to date, a reliable resource has a comprehensive article on evaluating your patients. Next slide. We feel that it's important to promote education and self-management for patients. So we think patients should be encouraged to actively participate in their own recovery. And for this reason, we have created a set of educational handouts on the most common long COVID symptoms. These are available at the website listed below, which is the UNC website. And there are also some other web resources which are listed and include patient education information. Next slide. Unfortunately, post-COVID conditions are magnifying health disparities, with vulnerable populations more likely to be affected, but less likely to have access to treatments. Vulnerable populations are more likely to hold frontline jobs, live in multi-generational homes or crowded places, have pre-existing conditions, and also more likely to have severe initial illness and require hospitalization. While at the same time, they are less likely to be vaccinated, access testing, receive acute treatments, and also access specialist healthcare. So this is something that we need to keep in mind and work together on reducing the impact. Next slide. So I've reached the end of my prepared remarks. I hope this has been helpful. And Liz, I'd be glad to turn it back to you for the next part of the presentation or discussion.
Great. Thank you, Dr. Baratta, for sharing your expertise on all the work that you've been doing with regard to long COVID. So for the next 5 minutes or so, I'd love to have a little bit of audience discussion with regard to some questions that I have come up with regard to long COVID. My first question is, what are some of the challenges that you're seeing in your clinics or with your patient population in diagnosing and or treating those impacted by long COVID or post-COVID conditions? And feel free to place an answer in the chat or come off of mute. And I guess we could also ask, are there any additional resources that you need or trainings that you might need for your patient population? And I guess maybe I'll throw this back at Dr. Baratta with a question. So in terms of prevention, what are some things that your clinic is doing in terms of, trying to hit long COVID before we see it in the patient population?
Yeah,
What type of education are you putting out there?
that's a great question. So unfortunately, anyone who gets COVID is at risk for developing long COVID. And we touched on that with the poll at the beginning of the program. As time goes on, we are developing better immunity through our own history of infection or infections, as well as vaccinations. So most, if not the vast majority of people residing in our country now have some degree of immunity towards COVID, but still we see it being transmitted. People are still getting it, and they can develop persisting effects. So I certainly encourage people in the community to remain up to date with vaccinations. The vaccines are overwhelmingly safe and effective. While they do not at this point completely eliminate the risk of COVID, as we had initially hoped for in late 2020. They are effective at reducing severe illness, and severe illness is associated with a higher risk of a long COVID or post-COVID condition. So certainly we encourage people to remain up to date with their vaccines to whatever degree possible. And also be prudent as far as their exposures. I think many in our country have left the concept of masking or personal protection, but I do think it's still reasonable to consider in individual circumstances and based on the conditions that you're in, such as particularly crowded areas or those with poor airflow. Yeah, thanks.
Great. We have a couple of comments. Amor O'Daniel says that they only have one physician and they've heard of community members, especially those with compounding ailments. They've needed to continue to stay inside or need oxygen, which must be very difficult with one physician treating that many patients.
Yes.
And then from Mr. Adams, who's a diabetes educator and diabetes consultant, he's interested in the relationship between the development of diabetes as a result of COVID-19 infection and illness. Can you speak a little bit more about diabetes?
Yeah, that's a really interesting.
That might be more at risk, or developing diabetes as a post-COVID complication.
Yeah, thanks for the question. That's a really interesting issue that is definitely seeming to have a relationship. People who have COVID seem to be at higher risk for developing a elevated blood sugar and diabetes within the full first year after COVID. So I don't know the exact reason why that is the case. I think that's not totally understood in the medical community yet, although there is research going on towards it. I think reasons why that could be primarily would center around inflammation. And I think an inflammatory response might be driving up the blood sugar and leading to diabetes. We do have some early literature suggesting that metformin, when given during the acute illness, can actually reduce the risk of developing long COVID. And this was published just recently, or it might even still be a pre-publication. So this is cutting edge stuff within the last couple of months, that there was a randomized clinical trial, and one group was provided placebo, one group was provided metformin, and during the acute illness in people who did not have diabetes. And the people who got metformin were at a substantially lower risk, 40 to 45% risk of reducing that.
Great. And is there any data on those who have, subsequent infections like 2, 3, 4, 5 infections of COVID? Are they more at risk for a long post-COVID complication than those who might have at one time?
Yeah, I think there is likely a compounding risk. So if you think of it as almost a roll of the dice, for lack of a better term, when someone gets COVID, on their risk of getting a post-COVID condition, the more the rolls you have, the higher the chance of having some persisting effects. We don't exactly know yet the particular factors that make someone have a post-COVID condition, whereas someone else does not have it, and so that will be the subject of ongoing research. But yes, people who are infected more frequently are at higher risk for developing long COVID.
Great. And so we do have time for another question or two before we wrap up. Please feel free to drop it in the chat or come off of mute if you have a question. All right, then we'll move on. All right, next slide, please. We can scroll down to the final slide. Great. So now we've come to the time where we can take our evaluation. As I had shared earlier, by completing this evaluation, you'll be able to get your CEU credit. If you're not interested in the credits, we would love for you to complete the evaluation. Anyway, we're always looking at ways to improve our programming, so any feedback is greatly welcomed. And I think Molly has also dropped a link in the chat in case you don't have a smartphone to capture the QR code. Leave that for a minute. Great, and the next slide, please. I just want to share some upcoming events that we have coming up next week and then the following week. May 31st, which is next Wednesday at 2 p.m., we're hosting an open forum. We'll be having one of our UIOs, Mr. Todd Wilson from Helena will be speaking on Beyond Burnout, weaving self-care into everyday practice, and he'll be sharing some of the things that his organization has done to work on that. And then on June 8th at 2 p.m., part of our HIV programming, we will be hosting a webinar branching out wellness programming for patient-centered HIV care from an urban Indian perspective. So those are two great events coming on the horizon. And next slide, please. Great, and one more final thank you to Dr. Baratta for sharing all of his insights and expertise with our audience today. We will follow up sending out this slide deck to anybody who might find it helpful, as well as a recording of this event that you can share with your communities. And if there's no further questions, we will conclude this session. Thanks again, Dr. Baratta, and thank you to everyone attending today.
Thank you, everyone. It's been a pleasure. Take care.